Pleased today to introduce our two speakers, my TIFA colleagues, Dr. Jeanette Kowalik and Dr. Karan Phillips. Jeanette is a former Commissioner of Health for the City of Milwaukee and was instrumental in the city action that declared racism as a public health crisis. And Karan has extensive experience in the Aging Network and teaches graduate classes in health equity in the older adult population. I know we're going to all learn today as well as be inspired. And also the presentation today is being recorded, and so we will be able to send the link out to you all, as well as the slide deck after the presentation today. So if everyone will please mute your phones or your laptops or your tablets, we would appreciate it. And I'm going to turn the presentation over to Karan.
Good afternoon, everyone. I'm very excited to be presenting to you all today. So as Megan introduced, the topic today is on reducing older adult health disparities. And to give you just a framework of how the training will run today, we're going to start with just an overview and highlight some examples of not only health disparities, but specifically health disparities amongst older adults. And then we will move into some specific examples that have particularly become pronounced during COVID-19. And I will turn the presentation over to our colleague, Dr. Kowalik, to present some of the recommendations and some of the ways that we have seen, and we encourage you all to share with us as well, as we would love to highlight them, ways that people are promoting equity and addressing health disparities in their communities, in their organizations, in their departments. So before we begin, as Megan mentioned, I am an instructor, so I like activities. So if you're able to, if you have your phone and you're using a computer, or if you have another screen, I have multiple screens, I invite you all to go to the link menti.com, MENTI.com, and then it'll prompt you for a code at the top, and use the code 2255024. And what we're going to do is just an activity. It's a kind of a visual activity, and I'll show you all what we're about to do. I'm going to develop a word cloud. So as you enter into the system, it'll prompt you with a question: what are health disparities? And I don't mean a textbook formal definition of health disparities per se. Just what do you think health disparities are? What does that mean when you hear the term health disparities? So if you could just share a few words about what health disparities are to you. What does that mean when you see the term health disparities? So what we're going to do is just kind of go through some of the things that are popping up on the screen. As you can see, transportation, internet access, cultural competence, social determinants, lack of equity, unequal access, inequalities across life, touching on that cumulative disadvantage perspective. I see housing, I see all kinds of great words. Let's see, advocate, inequitable. These are some great words. Unfair, inequity, inequities, all great words, all great things that definitely get to the root of what health disparities really speaks to. I'll let you all keep going for just a second, and then I'm going to transition to the next question as you all continue. All righty, I think we've about rounded up, and I'm going to capture this and share this when we send out the slides, so you all can see some of the words and some of the thoughts that you had. You can continue to submit. I'll make sure that they're captured. So the next question is, what does health equity mean to you? Again, some thoughts on those words of health equity, equal access, raising all boats. I actually kind of like that. Justice, fairness, community voice. Let's see, universal. They're moving, let's see, optimum health for all. Okay, let's see, I saw access according to need, equal opportunities, fair treatment, non-bias. We'll touch on bias a little bit in a moment. Optimum for all. Again, these words are just coming in and I'm just grabbing them as I see them. Engagement, needs met. Let's see, fair, health access, thriving. These are all really, really great. I'm going to do a few more. Help to the start line, accommodation, health literacy. Again, these are all really, really interesting, really, really interesting points. Thank you. I will capture these and share these word clouds to share with everybody when I pass out the slides. So thank you for indulging me in my education aside, just to get the juices flowing on this Wednesday afternoon. So I think it's important we ground ourselves in some definitions. And there are tons of definitions of health equity. There's definitions of health disparities out there, but we're going to ground ourselves in some of these as a framework for moving forward. So health equity is a fair, just distribution of social resources and social opportunities needed to achieve well-being. An environment where everyone has a fair and just opportunity to be healthy. And then the converse, health equity, differences in population health status and mortality rates that are systemic, patterned. Again, there's some of these words that are coming up: unfair, unjust, and actionable, as opposed to random or caused by those who become ill. And at the root of a lot of this is the concept of racism. And I will touch a little bit on some definitions of racism, well, race and ethnicity more specifically. But race is a human's construct. It was actually something that was created to try to develop a hierarchy. Racism is a system of structuring opportunity and assigning value based on social interpretation of how one looks, that unfairly disadvantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. Again, we'll talk a bit more about the foundation of race briefly, but again, a lot of inequity is deeply rooted in racism. And then we have the concept that I wanted to thread from our first training. We talked about implicit bias. And when it comes to older adults, there is a level of implicit bias about how older adults are expected to act and how older adults conduct themselves, and biases about what they're able to do and not able to do. So we're keeping that same thought of implicit bias as we begin thinking about what exactly health disparities and health equity means. So what determines our health? So I'm going to present a lot of images. I like pictures, and I'm going to present a model that highlights what determines health. So essentially, we're looking at health behaviors. I know a lot of us are very familiar with the Behavioral Risk Factor and Surveillance System survey from the CDC that looks at all these different health behaviors, our tobacco use, alcohol use.
I powered my laptop down and it's still.
And diet. Excuse me. Then we have our clinical care. So we have access to care and quality of care. Again, disparities speak to the issue of what kind of access do you have to care? What kind of quality is it? Is it based on your insurance type? Is it based on your location? All these things impact clinical care. Socioeconomic factors, big predictors of not only health outcomes, but access and availability of tools to promote positive health. Education, there's a high correlation between education and health outcomes. Employment, if you have the opportunity to have an employer that pays for your health insurance. Income, that's related to your employment, that's related to your education. Family support. I don't want to jump too far ahead, but read an interesting article about having access to the COVID-19 vaccine had a lot to do with familial support and having family members or someone that could take you to get the vaccine, or someone that could come and help the older adult access the websites. Again, a lot of the systems are using these computer-based portals, and the portals are maybe not even be that intuitive. I've heard that from a range of across the lifespan. I've heard that these portals are not necessarily all that intuitive, and it may take some additional assistance to help someone get online and get get support with that. So community safety, your physical environment. I always talk about the example of Aaron Brockovich and how you had a community that was experiencing health conditions based on the fact of where they live near a chemical plant. And there is environmental racism. Again, the property is cheaper in areas near highways and near factories. So again, there's poor air quality, potentially poor water quality in these areas as well. And do you have access to housing and transit? We can also even have a full almost training on rural health disparities. Again, access is limited in that regard due to transportation. I'm sure we could have a rich discussion around limited access to retrieve vaccines in rural communities and awareness with that regard. So another model I want to share with you all, or another figure, is same concepts, but again, highlighting the fact that socioeconomic factors make up 40% of the factors that determine our health. And then health behaviors. And this model, clinical care, represents a little bit less. This model predicts at 10%, but genes and biology and your physical environment, again, are all of these factors that have a really significant impact on your health and health outcomes. So let's look at the population. Look at some data, looking at our distribution of racial and ethnic groups. I want to talk briefly about the concept of race was created based on skin color and geography. It was not based off of science. It was not based off of something that had value or merit. It was based off of perceptions and skin color. Actually, in the 1700s, fun fact, a researcher named Leonidas, he divided men into 5 categories. There was Americanus, Africanus, Asiatics, Europeanus, and monstrous. Monstrous actually was a category to catch all people that had undesirable, as they called it, characteristics. So, and also, I also want to highlight here, and I'll reiterate this again, race and ethnicity are not interchangeable. I know that sometimes you'll see documents that say, well, what is your race? And it's like, well, I'm Hispanic. Hispanic actually is an ethnicity because you could be of one of several races or one of the other race, not necessarily just one race associated with Hispanic. So ethnicity and race are not the same thing. Race was created. Ethnicity is something that people can self-select into. Taking you all a little bit into one of my teaching lectures, but again, we're seeing an increase in the diversity of our nation. And we've all seen charts like this over the years, and they continue to show the same trend. Our nation is becoming more and more diverse. And by 2050, which I know may seem far away, but it's not too far away. But again, we see the same predictions that the percentage of racial ethnic minorities is increasing. And we will, who knows, maybe 2120 someone will have the same conversation again, be giving the same talk, and this might be all in equal quadrants of people of different groups. So interesting to, again, these are all grounding things to further our conversation. So now let's get specifically to our older adult population. How many older adults did not receive care or delayed care based off of their racial ethnic group? As you can see here, these are significant numbers, and these are some of the significant numbers that speak to a lot of disparities that we see in these communities. So as you can see that compared to their counterparts, their non-Hispanic white counterparts, African Americans, Hispanics, Asian American, American Native, and Native Hawaiian and other Pacific Islanders have higher rates of not going to see a doctor due to cost. Secondly, we're looking at delayed care due to other reasons. And again, we've talked about some of these reasons. It could be access. It could just be transportation. It could be cost. It could be lack of awareness of needing to actually go and see the doctor. I will share with you all, I've worked in affordable housing for a while, and a lot of the conversations and discussions that we had were centered on nutrition and chronic disease management. It used to hurt my heart to see seniors give away their fresh nutrition boxes. We would give them boxes of fresh produce, and they would give them away in exchange for Cheetos and quick to eat snacks, because they often could not prepare food for themselves, and they did not have any assistance to prepare the food. So as we, again, consider these percentages and consider these challenges, we're setting the stage for exactly what is happening with our older adults. And we're also setting the stage for this all existed prior to the introduction of this pandemic that we now find ourselves in. So in this slide, again, now we're highlighting chronic conditions amongst older adults of white, Black, and Hispanic backgrounds. Again, we can see the same trend compared to their non-Hispanic white counterparts. African Americans and Hispanics have higher rates of not only hypertension, but diabetes, asthma, and stroke. So again, we know these things. We know that this has been a challenge, and we know that this will consistently be a challenge unless we intervene and do our best to address it. But thankfully, we're aware of all these things, and now we can start looking at how we can promote equity and access, equity and program design, equity and helping older adults understand and receive better care and treatment across organizations and agencies. So with that, now that I've set the stage for you all, I am now going to turn things over to Dr. Kowalik, who will go through some COVID-19 disparities. And she has great firsthand experience working in the field as a public health commissioner, and she will share her experiences declaring racism as a public health issue. So it's a treat to have her share some of that information as well. Jeanette, I'll turn it over to you.
Thanks, Dr. Phillips. Good afternoon, everyone. So just acknowledging some of the information that's been shared so far, the reason for that. I know many people know about health disparities and health equity. There's various definitions. We feel it's always important to frame conversations based off of what we mean for the Trust for America's Health for this work, because we know that seniors, older adults have been impacted in many ways based off of who they are and where they live and where they were able to work and earn pensions or retirements. And so all of these things are linked to structural racism. And it's important to acknowledge that, because sometimes there is a tendency to want to place the blame or point the fingers on individuals for decisions that they've made as to why they are in the situations that they're in. And we know that there is an element of that, which was shown through the social determinants of health slides. However, when you look at what options are available to people, then you start looking at why people make the decisions that they make due to limitations that are provided or the quality of what is available to individuals. So we want to acknowledge that, first of all, there, for many people that have lost their lives due to COVID-19, the families that are still grieving, just everything that's happened over the last year, just acknowledging the loss and that we're in a state of grieving. It's important to just reflect on what's happened and what will end up happening for the rest of this year as we try to move out of this pandemic. But just noting that we are seeing pretty much the same distributions of inequities tied to structural racism. So just like you see the hypertension, the asthma, various health issues, you see the distributions across various racial and ethnic groups as well. And then when COVID started, we began to see the impact of COVID-19 in some of these same populations. And some of the questions at the time were, why is this happening? There was limited data. I was a health commissioner for Milwaukee, Wisconsin. We prioritized sharing race and ethnicity data for COVID cases and deaths because we believed that it was important to do that as early as possible because that helped us with our strategy for prevention. And that was tied to our declaration of racism as a public health crisis in the summer of 2019. So I just wanted to acknowledge the data sharing element of this, and collecting data by race and ethnicity is important to make sure there's a fair distribution of resources, that outreach strategies are tailored to various groups, and that the work continues. We're at the point now where we're able to receive a vaccine, which is wonderful that the technology has been so amazing, and that there's a vaccine right at this point in time, just basically. But the point of kind of looking back at how COVID has impacted our country, that we're seeing this inequity big time. And this slide here shows just, in essence, more recently, just, what we're seeing here, COVID-19 deaths by age and race. And you see who's being impacted the most: older adults. And then the categories, those like 10-year groupings, you see the increase is quite significant across the board, but mainly for Black or African-American individuals. One other point about this too is just reflecting as over my time as a health commissioner, one thing that we were seeing too was the distribution of where people lived or resided based off of being in alternative care facilities or assisted living facilities, nursing homes, and then people that were pretty much isolated at home and being cut off or not having access to resources. So we were seeing that most of our populations of color were being impacted outside of those types of facilities that I've mentioned, whereas more of the white individuals were being impacted through their residence at nursing homes and other types of related facilities. So we were seeing two crises playing out at the same time. So different interventions, considering that you have the congregate setting versus people being isolated at home, and how do you get to these individuals? So next slide. So this is something that everyone is aware of, but just we felt it was important just to give you a snapshot of some spatial data of what's happening. So you have in the green homes that are at least 25% Black and Latinx, and then you have less than 5% Black and Latinx in the orange. So you can just see the distribution of COVID cases here. And when you look at states, like when COVID began, it was out west, and then moving across the country, and then you start seeing other waves of COVID cases and fatalities. And we're in the wintertime, so obviously there's still more. We're not out of the woods yet, but just to give you a sense of the distribution by race and ethnicity and state, and who's living in nursing facilities versus who's not. And this slide is something that we love to share. We know that there's problems, we know that there's challenges, which is why we're invested in this work and passionate about this work. And just always a wonderful shout out and plug to our friends and partners at the John A. Hartford Foundation for supporting these efforts. But just through convenings and meetings and sharing, we wanted to highlight some things that are working. So in the state of Florida, they've created aging profiles, which have been expanded to include data on race and ethnicity. In Washington, there's a Center for Multicultural Health and the state health department partnered to develop and deliver culturally tailored brain health messages. And these messages were printed on hand fans that were disseminated in African-American churches. So if you know anything about African-American churches, Black churches, there was a rerun of the special of Black churches on PBS last night. But the fans, that's a very significant tool in the Black church. Is meant for one, fanning oneself when you know are trying to cool off from praising the Lord, but also for marketing. So various businesses and whatnot would have messages about their business on fans. So using that fan to advertise and support messaging for public health is a wonderful strategy. And then in Mississippi, through the State Health Department, the Office of Community Health Improvement has collaborated with the Office of Performance Improvement and Office of Health Equity to promote the inclusion of equity among older adults in the agency's strategic planning process. So it's important to acknowledge that if you're trying to do anything related to equity, it needs to be baked into how you function as an organization, whether you're a government entity, a public organization, a private organization. Including equity in your strategic plan is going to ensure that you're going to make it a priority. So we always like to see that. We always want to highlight when organizations are doing this and also share what this looks like, because sometimes it's difficult to move from concept to practice. And here's some additional examples of national efforts. So we have the promotion of physical activity and healthy eating among older adults. We know that access to food is a continued concern, and there's a great need through the pandemic, which we've learned through many of our regional sessions, just different ways that organizations have come together to provide healthy, nutritious foods for older adults. And then we have from falls prevention to brain health programs supporting healthy aging. So again, just looking at using government to bring about positive change. And oftentimes there may be an assumption that government entities are just regulatory and just focusing on essential functions and so on and so forth. But depending on the leadership of these government entities, there can be some really, really rich programs and services that are provided to older adults. So we again want to highlight these entities for their efforts, and also learn about other things that are happening that we want to share and learn about. And another point too, so in policy space, setting the wheels in motion through policy change is extremely, extremely important. And it can have very long lasting effects. So we also want to note that. Looks like there's something here in the chat. Yes, please. If you have anything that you want to share related to things that you all are doing, please include it in the chat so we can highlight it. Next slide. And then our federal partners, which we always like to make sure we're working together and supporting one another in our efforts. So the Federal Department of Health and Human Services recommends that we educate professionals to identify and address disparities that may be exacerbated with age. So when you look at professionals, it's a very broad group because there's a variety of professions that touch the lives of older adults. So making sure that the people that are working directly or supervising the people that are working directly with older adults are aware of what are the signs, what should they look out for to screen, to make sure that there's linkages to services is really important. Also, the need to collect community-wide data to help identify and map healthcare gaps in high-need areas, such as naturally occurring retirement communities. So data is key. If you don't have the data, it's very difficult to demonstrate that you're bringing about positive change or that there's a need for intervention. So you want to make sure you're collecting this data, that the data is rich, that you're making sure the data is including, of course, age and gender, but also you're seeking information about race and ethnicity. and then distributing information and implementing programs that address critical health issues later in life, such as HIV. I used to be the STD surveillance director for the city of Chicago Health Department. And, you'd be surprised, if you're in this work or you're not necessarily had experience at the local level, but just the need to educate the community and professionals about risks associated with sexual activity and whatnot. That it's not just for young people. You're a mammal. You should be aware that there is a concern. So definitely making sure that there's education and outreach and materials and resources for individuals to make sure that they're healthy and safe. And then we have our age-friendly public health recommendations. So the CDC's creation of a healthy aging unit, the COVID-19 Resource Center for older adults at the Federal Department of Health and Human Services, expanding AFPHS, age-friendly public health systems, which is high on our list. The strong focus on health equity. Again, oftentimes there's an emphasis to look at disparities. We want to make sure we're looking at equity as well, so that we can no longer have conversations about disparities because we've overcome those through policy and practice change. And then aligning and integrating age-friendly social movements. There are many movements across this country, lots of great ideas, and we want to make sure that we're learning about all of these wonderful things so that we can uplift and share what's happening. Okay, and then also advancing equity policy recommendations. So we have 4 categories listed here: ensuring equitable access to quality and affordable healthcare. So Medicaid expansion is important for that. We're not just talking about Medicare, but also the Medicaid, guaranteeing that there's universal health coverage. And, healthcare costs continue to rise every year. There has to be a pivot at some point to lean into universal health coverage, advocating for long-term investment in public health care and social infrastructure. The data piece, again, you need the data to support the change, and also to look at where the gaps are so that you can address the gaps. And then looking at public health foundational capabilities. We know that essential functions of public health was recently revised. Now that equity is the center of that. We want to make sure that the age-friendly work is embedded into essential public health functions. And then advocating for policies that address inequities and the social determinants of health. So we have HR 6561, we have SNAP, which is Supplemental Nutrition Assistance Program, and then the emphasis on paid sick leave, paid family and medical leave. So you're seeing more of this in the news. I used to be in maternal and child health, so we were talking about it all the time, but we're like, it's not just for having or providing care after the birth of a child. This should be in general that we're looking at paid sick leave, family and medical leave. And then identifying existing policy gaps and advocating for further federal support and health equity legislation. So making sure that resources are available. It's one thing to say that you want to focus on something, but there needs to be a financial investment, a resource investment, a workforce investment to address these issues. Great, so do we have any questions?
So Jeanette, there is a question from Richard, and he's asking, why isn't there wider public availability of census tract data, which should guide us on age, income, education level, including life expectancy, which is a proxy for the impact of social determinants of health?
I completely agree. I think that most of that data is so sporadic because my experience at the local level has been that various centers, organizations, academic institutions, that there has been some emphasis on making sure that level of data is available, but it's not uniform, which continues to be problematic. So it's like, how do you cross over what's working or examples of rich access to data in one community and share it with others? Part of the issue too is how data is collected. You're looking at the quality of data, making sure that there's staff that can actually clean the data and make sure data is in a format that can be useful. We know that there's a shortage of epidemiologists and other people that can make sure that they're analyzing data and translating it into meaningful formats. So, we're seeing again, all of this rising up through the pandemic, all of these needs that we've had for quite some time. But now it seems that there is going to be some positive change related to public health and data and access to data. So more to come on that. It's a great question, but we totally agree.
So for others of you who may have questions, please feel free to unmute yourselves, identify yourself and ask your question. And while you're thinking of those questions, I have one for Jeanette, for both you and Karan. And so for public health officials or public health practitioners at the state or local level who want to address disparities, what would you recommend for them as like the first step or the first action that they should be taking?
Sure, so I can kick this off and then Karan can will respond from her level of experience. But I think, again, a lot of the positive change has to happen at the top. So making the declaration that racism is a public health crisis is the first step. One is acknowledging that there's a problem. There needs to be an acknowledgement that there's a problem, because then that gets the ball rolling into taking action and creating solutions. So the declaration for Milwaukee was basically 5 action items that needed to be completed in a year. The first was associated with a needs assessment, which we love to do in public health, but a needs assessment for all city departments about how they function, what policies and practices are available that may be contributing to harm. So that's the first step. The next step was associated with generation of a report of recommendations for change. And the city's Equal Rights Commission was the responsible party for doing the needs assessment as well as creating the recommendation report. Then from that point, there was an action item related to hiring practices and professional development. So looking at, okay, a community's percentage of people of color or other forms of diversity, and making sure that the agencies that serve the community reflect the diversity of the community. So for instance, 50% of the community is of color, 50% of the city department should be of color, and not just at the community level or direct service level, but all levels of the organization, from executive leadership to middle management to direct service. And then the next action item was associated with helping to share the word, getting other communities or supporting other communities to make the same declarations. And then the last is more concrete policy change for the city. So the city wanted to make sure that we were modeling the behavior that we saw. And since we knew that we were responsible for our own house, we couldn't necessarily tell other businesses, this is what you need to do, when we knew we had things to clean up within our own shops. So that's just in essence what a declaration could look like. But then you move from that first year of accomplishing those action items into some other concrete steps. So for instance, housing, making sure that there's healthy, safe, affordable housing in the community, jobs, perhaps raising the minimum wage or providing some type of stipends or payments to low-income seniors or something along those lines. So there's things that can be done, but the community has to be a part of the development process of what they need. So every jurisdiction is responsible for creating a community health assessment and a community health improvement plan. And those documents are meant to guide what the focus should be or what services should be made available to the community. And there's a community advisory group that's typically tied to that. And then of course, a board of health would be involved. So you would look at these different elements as opportunities to make sure that you're addressing health equity in a meaningful way, that it's informed by the community, and that you're being very specific about the needs of older adults in your community, and not just assuming that organization X is taking care of that. You want to make sure that any aging organizations are a part of this process and helping to guide whatever services or interventions are going to be developed. For instance, another point about Milwaukee is that I was responsible for the city health department, but there were 11 other health departments in the county. So we all had to work together, but not necessarily override each other's decision-making authority. But the aging services for the area was housed in the county. So it wasn't like each city or health department had their own aging unit. Everything was pretty much delegated to the county to take care of. So there was a lot of disconnect, a lot of communication issues and whatnot, and opportunities for improvement. But just to give you a sense of what that means, and being very intentional about changing the situation, you have to include the people that are most impacted in the decision-making process, which also means that should be compensating people for their time. Many times people are participating on meetings and trainings and all of these things because it's a part of their job. But when you're looking at people that aren't working or retirees, you can't assume that, oh, well, they didn't show up to the meeting, that they don't care. You should be thinking about how do we honor these people's time and experiences by giving them some compensation for participating, and not just a good home cooked meal. It should be, something that is meaningful. So just reflecting on my HIV days where we would actually give people $50 to attend a meeting. So consumers or people from the community. So just some examples.
Thanks, Jeanette. Karan, did you have anything to add?
I completely agree. My experience is on the other side of what Dr. Kowalek's perspective is I was based in the community in affordable housing, and one of the things that we know is that without data, you can't really tell the story. I know I've learned really quickly that when you present a lovely little chart that says, hey, this is what's going on, this is what we need, people will say, oh, we didn't realize that was a significant issue. We know of the disparities, but it was a much more compelling story when you had it documented and you were able to present it to not only funders, but even potential partners. So having a strong needs assessment and having a strong baseline of where is everyone in terms of their health and their access needs, that's always a compelling piece to not only open doors to other opportunities, but to other partners. My second piece would be not only to partner with other organizations, but to partner with older adults. So again, echoing Jeanette's point, I am a big proponent of partnerships. I'm a big proponent of, we have this need, we have these resources, let's talk, let's figure it out. One of the things I enjoy about the work we're doing for age-friendly public health systems is that we talk about how organizations have operated in silos. Aging tends to operate a little separately from public health, and we're trying to get everyone to talk. Everyone should be at the table really talking about these issues. So it's not just, oh, we're doing this. It's like, great, but we could help you enhance that because we have this. And, it could be something as simple as a public health department has access to, everyone would love this, a mobile clinic. And it really needs to go out to this one particular community where there is no transportation line. I know during my time in Richmond, one of the concerns we had was how are we going to get them to various resources that they need, given that it's on the other side of town. So how do we get the resources to them? Because sometimes they won't go, sometimes they can't go. How do we get it there? So simple partnerships begin to address those issues. We actually were able to bring in providers to the facility to help bring health screenings in weekly. Again, no money exchange, no, only thing we need was the MOU. So I'm big on partnering, and I am definitely a proponent of making sure the community's at the table. We can strategize all day and come up with a great plan, and it's not effective. I was sharing with Megan earlier before the call started of a situation where people made a lot of assumptions about how to engage the community, and they did not really understand that you need to be grounded in what actually is the dynamic of the community before you can actually work with them. So I definitely agree that older adults should be at the table as well, because there's not, we can, again, strategize all day, but it wouldn't necessarily have the impact that is desired if it's not, designed with the thought of the person that's going towards in mind. There's a
Awesome. That's
question.
a really, really practical example. So thank you both. And was someone getting ready to say something? Did I cut them off?
No, I said there's a question in the
Okay.
chat.
So there is a question in the chat from Harriet. Why is it so difficult to get funding for innovative preventive health programs that address inequity? Is it because prevention is difficult to measure outcomes, lack of a funding infrastructure in public health?
Sure, so I can kick this one off. So you need data to demonstrate evidence and also to get funding and maintain funding. So it appears that the biggest challenge has been standardizing equity data. So how do you measure equity? Everyone measures it in different ways. And when you're looking at like local measures, for instance, Oakland, they have their plan. This is what the measures look like. You look at the next city, they don't have measures, but they acknowledge that it's important to address equity. So there's been many efforts to standardize how you measure equity, but there hasn't been a unified sense of this is the index that we're using. There's like the social vulnerability index that the CDC uses, but some people are like, oh, we don't use that. So that's part of the issue, is that there's many ways to demonstrate that equity is something that can be measured. But when you look at it, it tends to be very specific to what data is available. So oftentimes that is a big issue. If you don't have access to consistent and reliable data, it's hard to use it. But it might be nice if you had it, but you don't have it, so you don't use it. So that's one thing. The other thing too is there was so much emphasis on evidence-based, right? So you know what that means if you're a researcher. You actually conducted a study, you have a control and experimental group, you did the statistical analyses, and there's significance. So you can say this is related to this, or whatever the case may be. And we know that with equity, it's not that black and white, or black or white, that there are many variables that can contribute to specific social determinants of health. So, that's another concern too, is kind of moving out of this, well, we're only going to focus on the evidence, or things that have had a RCT or a gold standard study, but also acknowledging that there's different ways to capture things that are working that don't necessarily have that type of setup, whether it's like emerging practice or something to watch, or promising practices. And you'll see this, in various places across the country, but just acknowledging that there's different phases or growth cycles for interventions, and that everything can't be a study per se.
Ron, did you have anything to add?
No, that sums it up for me.
And I would just add too that, for prevention, if public health is doing its job right, then you don't see the problems, and then it's difficult to justify additional funding, additional infrastructure, additional staff, and other resources. So, if you're doing your job, it's hard to account for what needs to change. But it's a really good question. Of course, we've seen during COVID that if there was more infrastructure in place, then I think there could have been even better response. Public health is doing an amazing job, and has been for the last year. So we really appreciate all that you all are doing, and know that there's still a lot more work to do. But we acknowledge and appreciate you.
Thank you, Megan, for bringing that up. When you're doing your job and there's no outbreaks and everything is under control, and you're out of sight, out of mind. But public health is a profession where It's more about the intrinsic value for doing the work. You don't need to be out front. You don't need to, have all the press conferences and see your face everywhere. It's more about you're caring and giving back. So oftentimes that people don't see you because you're doing a good job. So I say that. And then another point, just reflecting, on all of the work that has been done to date. So, looking at like reframing how we see this work, health equity work, that you have to understand that not everybody's going to care as much as you do. I'm a Black woman, I care, because I'm directly impacted by it, but I also have seen, things happen over time. And just like the stories from my family members and, depending on where you grew up and where you went to school and it's everything, our lived experiences per se. So, in essence, we're looking at how do you appeal to people? How do you get people to care? And, it takes a lot of listening. It takes a lot of moving out of your comfort zones and maybe talking to people you don't necessarily agree with or assumptions that you may not agree with them because of their political leanings or wherever they're from or whatever the case may be. So just the power of storytelling is something that is very underestimated that I think we need to continue to bring it in and really embrace it because that's normally how you appeal to people. If any of you have been to congressional briefings, you always have these wonderful people, up sharing their stories about why they support this bill or why this needs to be passed. And those things you never forget. Like they say, you never forget how someone made you feel. Mm-hmm. So just, again, this thinking that, yeah, I really care about this. Someone else may not, but how do we find some middle ground or how do we create a space to share information? So.
That's a great point, Jeanette. I totally agree with you about stories. They're so impactful. One of the most influential ways to present your case or to advocate for changes.
Thank you.
Any other questions or any other comments? All right. Well, thank you, Dr. Phillips and Dr. Kowalik. We really appreciate your sharing your expertise and your experiences with us today. And just to remind everyone that we will be sending out a link to this presentation as well as the slide deck. And someone also requested that we send the link to the earlier our first training from January, and we can certainly do that as well. So we appreciate that recommendation. I appreciate all of you and for what you're doing. Keep up the good work and stay tuned next month for our third in our training series for age-friendly public health systems on the 3rd. It will be the 3rd Thursday of March. And so we look forward to seeing you then. Our topic will be addressing social isolation and providing a lot of recommendations, and particularly in the context of COVID and delivering the vaccine. So thank you all very much. We look forward to seeing you next month. Thanks, everyone.
Thank you.
Thank you.
Very much. Thank you very much. Thank you.